Okay, a very warm welcome to our audience to today's IVPN Journal Club session. I see there's many of us already, which is great. We will begin today's topic or today's session on the topic of aspirin versus low molecular weight heparins for thromboprophylaxis after fracture. I will first have a few opening remarks by Dr. Ahmed Al-Waini, preceptor and hospital pharmacist at Gulf Medical University, UAE. So let's proceed with his insightful remarks.
Sorry, Dr. Salma.
In Gulf Medical University, UAE. Without further ado, I will leave the stage for mic and screen to Dr. Salma to moderate this session and introduce our speaker. Wishing you all the best, Dr. Salma, and enjoy this session. Thank you.
Thank you, Dr. Ahmed, for the warm presentation. Again, welcome to our audience. Today, on today's Journal Club session on the topic of aspirin versus low molecular weight heparins on thromboprophylaxis post-fractures. So I myself will introduce today's keynote speaker, which is Dr. Doha. So Dr. Doha Hamoud is a master's candidate in industrial pharmacy at the National University of Pharmacy in Ukraine, class of 2024, inshallah. In addition to her studies, Dr. Doha has had the privilege of working as a professor assistant in research at the National University of Pharmacy in Ukraine, specifically in the departments of biochemistry, pathological physiology, as well as drug industry technology. These experiences have enriched Dr. Doha's understanding of pharmaceutical research and practical applications. Furthermore, Dr. Doha is actively involved as a researcher for the Oli Health Magazine organization, where she works on cutting-edge research and publications. These opportunities have deepened her passion for pharmacy and reinforced her commitment to improving patient care. So without further ado, Dr. Doha, please, the floor is yours.
Thank you so much for the kind introduction. And today I will be exploring the potential use of aspirin as an alternative to the low molecular weight heparin in preventing venous thromboembolism in fracture patients. I will discuss the latest research, clinical trials, and comparative studies to evaluate the efficacy, safety, and practicality of aspirin in this context. Okay, so my topic for today is aspirin or low molecular weight heparin for thromboprophylaxis after a fracture. Sorry, can you see my screen?
Yes, Dr. Doha, we can see your screen.
Okay. I would like to highlight the significant article that has greatly influenced my research and understanding of the topic at my hand, recently published by the esteemed Journal of Medicine in England in January 2023. The article has provided valuable insights into our discussion. As a background information, I will be providing about the venous thromboembolism, the VTE, that refers to the formation of blood clots in the veins, leading to conditions such as deep vein thrombosis and pulmonary embolism. Fractures and immobilization lead to stasis of the blood flow, endothelial injury, and hypercoagulability, by that increasing the risk of venous thromboembolism. And additionally, immobilization and fracture surgery contribute to venous stasis, endothelial damage, and further clot formation. Thromboprophylaxis is the preventive use of medications like anticoagulants or antiplatelet agents to reduce the risk of blood clot formation and VTE in patients with fractures. What was the need for this study? The lack of comparative trials between aspirin and low molecular weight heparin for thromboprophylaxis in fracture patients, the uncertainty regarding the superiority of low molecular weight heparin over aspirin, the need for cost-effective and accessible alternatives to low molecular weight heparin. In addition, that the study aims to evaluate the efficacy and safety of aspirin versus low molecular weight heparin for fracture thromboprophylaxis. Findings will contribute to evidence-based guidelines and treatment decisions for fracture patients. The study objectives were to compare the effectiveness and safety between aspirin and low molecular weight heparin, to determine if aspirin is non-inferior to low molecular weight heparin in preventing death, assess the incidence of deep vein thrombosis and pulmonary embolism with aspirin versus low molecular weight heparin, and to evaluate the safety profile and adverse events associated with both thromboprophylactic agents in the study population. The author's affiliation, the disclosure the study was funded by the Patient-Centered Outcomes Research Institute, and it was conducted by the Major Extremity Trauma Research Consortium. And the author's affiliation at the different departments of orthopedics at the Universities of Maryland, Johns Hopkins Hospital, University of Utah, University of Washington, Carolina, and at the Harvard Medical School in Boston. The study design was a pragmatic, multi-center, randomized, non-inferior trial. The participants were randomized in a 1-to-1 ratio to receive either low molecular weight heparin or aspirin for thromboprophylaxis, and the low molecular weight heparin group received 30 milligram of enoxaparin twice daily, and the aspirin group received 81 milligram aspirin twice daily. The treatment adherence was monitored during hospitalization, and thromboprophylaxis duration was varied based on the hospital protocols, and patients were followed up for 90 days to assess the outcomes. The inclusion criteria, as mentioned below, the adults aged 18 years or older admitted to participating hospitals for medical or surgical reasons, had anticipated the hospital stay for at least 3 days, and were at an increased risk of venous thromboembolism based on their medical condition or surgical procedure, in addition to being able to provide informed consent or had a legal authorized representative who could provide consent on their behalf. The exclusion criteria for people who were receiving anticoagulant therapy, for having hypersensitivity or contraindication to these medications, having history of bleeding disorder or active bleeding, also having severe renal impairment or end-stage renal disease, and the history of recent strokes, ischemic attacks, intracranial hemorrhage, or for patients having life expectancy of less than 3 months, in addition to the pregnant breastfeeding woman, and others participating in another clinical trials that could interfere with the study, or being unable or unwilling to comply with the follow-ups and study procedures. The primary and secondary endpoints of the article, the main focus of them were to evaluate the occurrence of major bleeding event as primary endpoint. And the major bleeding events included the fatal bleeding, symptomatic bleeding in critical organs, bleeding necessitating hospitalization or transfusion, significant drop in hemoglobin levels, and the hemorrhagic events requiring intervention. The study examined the secondary endpoints also, which were major adverse cardiovascular events, the MACE, which included cardiovascular death, non-fatal myocardial infarction attack, non-fatal stroke. The researchers who also analyzed individual components of MACE, all-cause mortality, non-major bleeding events, and the net clinical benefits were combined between major adverse cardiovascular events and the major bleeding events. The patient's baseline characteristics, the average of patients in both the aspirin and low molecular weight heparin were similar, with an average of around 44.6 years, as we can see here. And the majority of patients in both groups were male, accounting for approximately 62% of the total population. The non-Hispanic white constituted the largest racial or ethnic group in both aspirin and low molecular weight heparin, comprising about 63% of the patients. The median body mass index, BMI, was similar in both groups, with values around 27.4. Risk factors such as previous venous thromboembolism, cancer, diabetes, and smoking states were present in a subset of patients, with a prevalence ranging 0.7 to 8.3%. And the injury severity scores were similar between the two groups, with a median score of 9. The primary outcomes and the secondary, the primary outcomes related to the 90 days of mortality. The 90-day mortality rate was similar in both aspirin and low molecular weight heparin groups, with approximately 0.78 and 0.73% of patients dying from any cause, respectively. And the difference in mortality between the two groups was not statistically significant. According to the secondary efficacy outcomes, the incidence of cause-specific death related to pulmonary embolism was low and comparable between the two treatment groups. No statistically significant differences were observed in the incidence of different types of pulmonary embolism, like massive, submassive, between the two groups. And the occurrence of deep vein thrombosis differed between the groups, with a higher incidence observed in aspirin group compared to low molecular weight heparin group. The secondary safety outcomes, both treatment groups had similar rates of bleeding complication, wound complication, and infections. No statistically significant differences were observed between both groups regarding these safety outcomes. Okay, the primary outcome, death from any cause, showed no significant difference between aspirin and low molecular weight heparin in both groups, the intention to treat and protocol population. This is illustrated by the number of deaths, 47, 0.78% in the aspirin group versus 45, 0.73% in the low molecular weight heparin group in the intention to treat the population. And the difference in proportions was 0.05 with a confidence interval between minus 0.27 to 0.38. Moving on the secondary efficacy outcomes, the study examined cause-specific death, death related to pulmonary embolism, and death possibly or likely related to pulmonary embolism. The results showed no significant differences between both of them. For example, the proportion of death related to PE in the per protocol population was 14, 0.26% in the aspirin, compared to 10, 0.18% in the low molecular weight heparin group, with a difference in proportion of 0.04 and a confidence interval of minus 0.09 to 0.02. Regarding the different types of deep vein thrombosis, DVT, including the massive, submassive, clinically significant, asymptomatic, segmental, and subsegmental, there were no substantial differences in the incidence between the two groups, and the percentage of patients with each DVT type were similar in both groups, indicating comparable efficacy. For instance, the proportion of patients with segmental deep vein thrombosis in the per protocol population was 59, which is 0.98%, versus the aspirin group, which is 52, 0.86%, and resulting in a difference of 0.12 and a confidence interval between minus 0.08 to 0.31. The limitations of this study were the sample size and the generalizability, which has a relatively small sample size, which may limit the generalizability of the findings. The trial included a total of 500 participants, with 250 in the aspirin group and 250 in the low molecular weight group. Patient population included patients with acute ischemic stroke or transient ischemic attack who had additional risk factors for venous thromboembolism. And for example, the trial predominantly included other older adults and may not fully represent younger stroke patients or those from different ethnic background. It's important to consider that the risk for the venous thromboembolism and bleeding event could vary over extended period, and the trial's findings may not fully reflect those long-term risks. As a conclusion, in patients with extremity fractures treated operatively or with pelvic or acetabular fractures, aspirin was found to be non-inferior to low molecular weight heparin in preventing death. Aspirin was also associated with low incidence of deep vein thrombosis, pulmonary embolism, and a 90-day mortality. These findings suggest that aspirin could be a suitable and cost-effective alternative for the thromboprophylaxis in patients with fractures. Here we can see the second trial, which is relatively similar to the metric trial, where aspirin versus low molecular weight heparin for venous thromboembolism prophylaxis in orthopedic trauma patients was also taken into consideration. And it's a separate study that specifically compared aspirin with low molecular weight heparin for VTE prevention in the fracture patient. And overall, both articles contributed to understanding of venous thromboembolism prophylaxis in orthopedic trauma patients and provide insights into the effectiveness and safety of aspirin compared to other treatments, including low molecular weight heparin. As a conclusion for me, and based on the findings of the Prevent Clot trial, I conclude that aspirin is a viable alternative to low molecular weight heparin for thromboprophylaxis in patients with fractures. Considering the lower cost and oral administration of aspirin, it may offer practical advantages over low molecular weight heparin in terms of accessibility and convenience for patients. These findings highlight the potential of aspirin as a valuable thromboprophylaxis option for patients with fractures, and further research can explore its use in other clinical settings. The applicability in daily life. The Prevent Clot trial findings have practical implications for daily clinical practice. As I mentioned before, it's being effective and convenient alternative for preventing blood clots. The oral administration of aspirin eliminates the need for injections and making it more accessible and patient-friendly. Aspirin affordability and widespread availability make it a feasible option in various clinical settings, and the trial results suggest that aspirin can be safely used for thromboprophylaxis beyond fractures and benefiting a larger patient population. Here are the references I used for my presentation and the article. Thank you so much.
Thank you, Dr. Doha, for the very insightful presentation. I think you did an amazing job highlighting the key points and making it easy for our audience to have a quick review of such an important article. I now want to encourage our audience to just ask whatever questions you might have for Dr. Doha in the Q&A chat box below. While some of our attendees send in their questions, I would actually like to ask some questions of my own to you, Dr. Doha. So what do you think, or do you think a similar conjecture, similar hypothesis could be, applied to maybe DOACs or other antiplatelets like clopidogrel? Do you think these findings will maybe just apply to aspirin or other antiplatelet and anticoagulant medication in general?
I think other antiplatelets can have the same efficacy and can be also applicable, but as we know, it needs more research and the clinical trials to be 100% sure not to cause any adverse effects for patients.
Mm-hmm. Definitely. And I think also the fact that DOACs might be a more expensive alternative might differ from if aspirin
is the most effective and costly for cost effective for patients and the easiest to be administered by all.
Definitely. I have one of the attendees requesting if you can go back to the article title slide,
yes,
so that they can refer to it. Another question I had, Dr. Doha, do you think it would be maybe more clinically applicable or more interesting to apply these findings in a specific population? I'm thinking of maybe a geriatric population that is more at risk of fractures, maybe women with osteoporosis.
Yes,
do you think such findings would be more maybe
applicable,
because
it's
or
still
interesting?
Limited. According to the population they tested this trial, it should be more worldwide and global in different populations to be more effective and to be also sure if it will show the same effects to all.
Definitely. I agree with you, maybe the sample size being a bit limited.
Yes, it's a little bit limited.
Right. Okay. Any questions from the audience in the QA box? Not yet. I personally find it a really interesting topic. I personally teach the emergency department rotation for PharmD students at our hospital. So obviously this topic is something I am, eager to share with them, in the management of fractures. Let me see if we have any questions from any of the participants so far. Nothing yet. Another question I had for you, Dr. Doha. So there was a slight difference in the DVT percentage, right? It was, I believe, slightly higher for the aspirin group.
Yes.
I think. Why do you think that might, happen? Is it just out of purely molecular chemistry of the drugs, or maybe certain patient characteristic that might have?
I think it may differ according to patient's characteristics, or not related to the general chemical compound. So
Sure. Okay, so we have a few questions here. One is from Dr. Abdul Wakil. He is asking, what is the target for low molecular weight heparin? So, doctor, in terms of population dosing, would you clarify your question? Another question from an anonymous attendee asking if aspirin can be given together with low molecular weight heparin as prevention. So having the dual therapy instead of monotherapy.
yes, maybe with exact doses it may be applicable, but I can't assume right now if the dual therapy can work effectively according to the case also.
Any more questions from our attendees? Nothing so far. Do I have another question from my side? The target fractures of this article were extremity fractures, right? Regarding pelvic bones, metacarpal, metatarsal fractures. So do you think this is something that can also be applied to patients that have maybe other types of fractures? I'm thinking spine, or should we be more precautious with those types of patients?
Yes, with those types of fractures, precautions, and it must be, and we must be more certain. And now this trial is still under the process and under the provision of hospitals. So I think we must be more cautious while doing for such fractures. But for right now, for orthopedic fractures and extremities, it can be applied normally.
Sure. Okay, we have a few questions from Dr. Kashaf Sheikh. He is asking that the article, or he's confirming the article gave 30 mg BID as prophylactic dose, correct? I believe for the enoxaparin.
30 milligram enoxaparin, yes, twice daily.
Twice daily. He would like to confirm, isn't the prophylactic dose 4 times daily?
I didn't get the question.
He is just confirming, because I think this is based on Canadian guidelines, right?
Yes.
The
American guidelines.
American guidelines, sorry. So he just wanted to confirm what would be the actual prophylactic dose of enoxaparin so far, if it is twice daily or,
Yes.
sorry, once daily.
30
Dr.
milligram
Kashaf.
twice daily.
So in the article, it was twice daily, but the actual guideline so far, is it a once daily dose?
I'm not sure, but I think no, it's twice daily.
Okay. Dr. Abdul Wakil here also asking what would be some contraindications of low molecular weight heparins?
As we can see here, mainly low molecular weight heparin had more, not significantly, we can say death related to pulmonary embolism and especially to different types. So most of them
Probably
were,
some of the exclusion criteria, I believe also, right?
yes,
To enoxaparin contraindications.
yes.
So again, Dr. Kashaf, I'm reading here to confirm that the prophylactic dosing of enoxaparin is once daily, not twice daily as stated by the article. I guess depending on the patient's weight, right? The dose would be adjusted.
Yes, of course.
Again, Dr. Abdul Wakil asking what would be the best time to give low molecular weight heparin?
According to this article, it was given in the morning and in the evening because it was given twice daily. But in general, it's mostly given in the morning.
Sure. Any more questions from the audience? Dr. Asra is just confirming for the route of administration of enoxaparin in the article.
It's injection.
Subcutaneous injection.
Yes. And the
Any more
aspirin is given
questions from
orally.
the?
So that's why it's showing how more it's convenient.
Definitely for patient adherence and ease of administration. Again, Dr. Abdul Wakil inquiring about the antidote of low molecular weight heparin in case of overdose or toxicity.
For low molecular weight heparin?
Yes.
Can you hear me?
Yes, Dr. Doha?
Yes. I'm sorry. I think my connection is a little bit unstable.
Yes, we can see you now.
Yes. As low molecular weight heparin, mainly protamine sulfate is usually used as an antidote.
Sure. Any more questions from the audience for Dr. Doha on today's topic? Okay, so Dr. Asra, just to confirm, is there any oral low molecular weight heparin available in the market so far?
I don't think so. And usually low molecular weight heparin is only given in hospitals in the form of injections.
Let me just refresh the QA box. To see if we have any more questions before we close today's session. Okay, well, if no more questions so far, thank you, Dr. Doha, very much for your wonderful presentation today. Thank you to our audience for the... Oh, we have a few more questions actually before we close. Dr. Rafia asking what would be an oral anticoagulant then to go for if heparins are not available as IV.
Like edoxapan, apixaban, usually
Rivaroxaban, all of the other DOACs available, although not studied in this article. A question from one of our anonymous attendees, in DVT, what would be the best option for treatment? So I think enoxaparin remains the first option in DVT treatment and prophylaxis in most guidelines so far, which is why this article is one of its kind in kind of comparing the efficacy of aspirin as compared to that. So the name of low molecular weight heparin studied in the article was enoxaparin.
Yes.
Yes. So now, if we have no other questions, I will close to this session again with thanking Dr. Doha, thanking our attendees today. Just a few closing remarks before I leave you. I would like to encourage all of our attendees, as well as welcome all of you to join the IVPN Journal Club listserv if you're not yet a part of our vibrant community, to make sure you have endless opportunity for growth in the pharmacy field. You can register at our website, www.ivpn-network.com, and register to the listservs such as the Journal Club, but not only, we have many other listservs you can subscribe to. Please note that the certificates of attendance will be issued within 7 days of completion of today's session, and that the recording and presentation slides of Dr. Doha will be available on the IVPN library website within 15 days. Please stay tuned for the upcoming new activities with the IVPN Journal Club listserv. Thank you very much for trusting in IVPN and being passionate about advancing your expertise in pharmacy. Have a very good evening or rest of your day. Thank you very much for attending, and see you soon, inshallah.
Thank you so much, Dr. Salma, for your kind words, and thank you for having me today.
Thank you, doctor. It was a pleasure. See you soon.
See you. Goodbye.